Tearing the ACL, the anterior cruciate ligament. Injuries to the anterior cruciate ligament are relatively common in sport, especially AFL, basketball, netball, and skiing. Historically, ACL injuries have prematurely ended sporting careers. However, current surgical and rehabilitation practices enable most athletes with ACL injuries to resume regular sporting activities. ACL injury facts. The ACL provides 90% of the stability to the knee. 100,000 new ACL injuries occur each year. Women are 3 times more likely to suffer an ACL tear than men. 90% of individuals who undergo surgery will return to sport within 6 months. 13 to 15% of people who have injured their ACL will experience subsequent injury. In this video, I am going to discuss the location of the ACL, how the ACL is torn, and the rehabilitation process after tearing an ACL. I hope you enjoy the video. There are 4 major ligaments that provide the knee with stability. 2 collateral ligaments are positioned on the outside of the knee to provide side stability. The medial collateral ligament is positioned on the inner side of the knee, whilst the lateral collateral ligament is positioned on the outer side. 2 ligaments cross over in the centre of the knee, forming the cruciate ligaments. The front ligament is the anterior cruciate ligament, ACL, and the back ligament is the posterior cruciate ligament, PCL. The ACL prevents the tibia bone from moving forward, whilst the PCL prevents the tibia from moving backwards. When the ACL tears, the tibia can move forward too much, making the knee unstable. An ACL tear occurs when the upper leg rotates while the foot and lower leg are planted. Let's have a look at how an ACL can be torn during sport. There are several signs that may indicate an ACL tear, including a pop or crack in the knee, a few minutes of severe pain, the knee giving out, swelling and instability. During the first 72 hours, the athlete should follow the no harm and RICA principles. These principles will help reduce bleeding, swelling and damage within the joint. The no harm principle stands for no heat, no alcohol, no running, no massage. The RICA principle stands for rest, ice, compression, elevation, and referral. A sports medicine professional should be seen as soon as possible to determine the extent of the injury and to determine treatment. Most ACL tears can be diagnosed by physical examination alone, but X-rays and MRIs are sometimes used. The medical professional will guide the athlete in deciding whether to surgically operate on the ACL or not, considering reasons such as age, if the individual needs a fully functional ACL, knee stability, social factors including the cost of treatment and time away from work, and associated injuries. If surgery is not chosen, there will be an extensive process of physiotherapy to restore knee strength and stability. In most cases, the ligament can't be repaired, thus the ligament is constructed using another ligament or tendon. The patella tendon is most commonly used for reconstructive surgery. The ligament can be reconstructed using the patient's ligaments, autograft, or by using ligaments from a cadaver, allograft. It takes 6 to 9 months for a full recovery after ACL reconstructive surgery. After surgery, the individual should focus on restoring motion, strength, and improving the stability of the joint to prevent future injury. During the first 2 weeks after surgery, the focus should be on range and motion exercises to strengthen the quadriceps and hamstrings. The aim of the first 2 weeks is to gain full knee extension and flexion. This is shown here. Work should be done with a physiotherapist, including gentle strengthening and aerobic work. A great way to improve strength, motion and aerobic ability is on a stationary bike. Self-massage may help with the pain relief and speed up the healing process. Self-massage is shown here with the use of a roller. During weeks 3 to 6 of recovery, work should be continued with the physiotherapist, with the emphasis being shifted to strengthening, balance and proprioceptive exercises. Appropriate exercises include balancing on one leg and holding for 5 to 10 seconds, slow mini squats, and slow one leg mini squats. During weeks 7 to 12, the athlete can begin activities that require low to moderate weight bearing, such as cycling, slow jogging, and pool workouts. At this stage in rehabilitation, it is still important to avoid activities that require sudden stopping or pivoting. During the remaining months, the athlete should partake in sport-specific activities. For example, a soccer player would commence controlled dribbling and kicking drills, and a tennis player would commence hitting balls. Although the knee may begin to feel normal at this point, it is important to remember it is not ready for the stress of all activities. Returning to sport depends on a number of factors, including the individual's progression through their therapy, the graft type used. If the ACL was reconstructed using a donut, it is believed to take longer to heal. The final decision will come down to the surgeon and the physiotherapist who guided the rehabilitation. Criteria for returning to sport include resolution of pain, no joint effusion present, less than a 10% performance and strength deficit when compared to the uninjured knee. Once the athlete has been given all clear to play, it is still very important to protect the ACL for years to come. To prevent a subsequent injury, the athlete should continue with strengthening exercises, ensure a sufficient warm-up and cool-down when participating in physical activity, and monitor the level of stress being placed on the knee. Your doctor or physiotherapist may recommend strapping your knee when participating in activity. It is important to remember to follow the doctor or physiotherapist's instruction to ensure a quick recovery and minimize the chance of reoccurrence. Thank you for watching.